Good to see you. Thank you so much for showing up. I just want to do a couple of things real quick, some good housekeeping, and then I want to get right to this because this subject is very, very, very important to me. First and foremost, thank you. Thank you so much for making one of my biggest dreams come true. I actually didn't ever imagine that this would really go anywhere. I was just kind of wanting to do some education, maybe locally. Much. Same rules apply. If you find this educational, please share it. It's free. I'll answer as many questions as I can. Send the questions afterwards. Have friends send questions. I try to answer all of them that I can with the very little free time that I have, but I'm just very happy. You've made my year, so thank you. Okay, second one. I have to give a shout out to Karina Perez, because she saw my Clemson hat in some of my pictures, and she knows I went to Clemson a couple of times, and she made me a Clemson scrub mask. So that is really, really cool. Thank you so much. I just needed to shout that out because I think it's so cool. All right, I think that's it for housekeeping. I do have my daughter's unicorn towel because I don't know whose great idea this was to do this outside. It was my idea, but it is literally 100 degrees outside, so if I'm sweating, you can make fun of me silently. All right, here we go. Breast cancer. Most of you guys know this, and I'll just start off. I won't make it a big story again because most people know this, and if you don't, I'll keep it short. But breast cancer is very personal to me for multiple reasons. The first one is that my uncle David, ended up with breast cancer. Typically that is men are 1 to 2% max that will actually end up with breast cancer. But we have an unfortunate genetic disorder in our family. We have what's called a BRCA2 gene. A neat educational tidbit. BRCA is BRCA. A lot of people, I think, believe that it stands for breast cancer, BRCA. I believe it actually is for Berkeley, California, where they isolated the gene. But it's a nice run-on and a nice acronym. Nonetheless, family to basically find out that we had that disorder. He fought stage 4 breast cancer for, I believe, 11 and a half, almost 12 years. Because of him, other men in my family and women, but no women have actually turned out positive yet, which is a blessing. But all the men in my family who have turned out positive have been able to do something about it. So my cousin, which is his son, and my twin brother ended up having bilateral mastectomies because of that, and it's likely going to save their lives. So that's why it's very personal to me. So it's a personal touch. So nonetheless, moving on, I just wanted to kind of give you a tidbit about why it's more than just a job. All right, I want to talk about screening, predisposition, and very, very important for multiple reasons. One, it used to be that screening people would say, oh, I'm going to get my mammogram every year starting at 40. If I have dense breast tissue, maybe they'll do an ultrasound because ultrasounds are better with dense breast tissue, and that's a good thing. What people don't take into account is that we have gotten astronomically better at screening. And this is a big kudos to my radiology friends. We have now come up with 3D mammograms, which are really good with dense breast tissue, extremely accurate with the location. Shout out to the hospital that I work at because we're getting our 3D mammo machine. I think it's coming, in 1 week. Say a prayer, if not, just in the next couple of weeks. And this is a big jump. It's a huge jump. We also have MRI that is specific for the breast. That is an unbelievable undertaking. These are just things that have come out really in the last 5 years. They've come on really strong and they've changed the game immensely. Breast cancer is now, people say it's more prevalent. I'm going to argue that it's not necessarily more prevalent. We're just finding it in much earlier stages. Stage 1, stage 2 maybe, rarely stage 3 and 4, only because women are extremely diligent. The word is out. and you're mobilizing, you're getting your exams done, and I think that screening changes everything. It changes the game. It's accuracy. So that's my plug on screening. I think you should start it at 40. You can even start it a little earlier if you have concerns, or you're lumpy or bumpy and you just have concerns about that. There's nothing wrong with starting at screening early. 2, you can start 10 years prior to the youngest person in your family who ever had breast cancer. So let's just say that your mom or your grandmother had it at age 45. In that case, you would want to start your screening at 35. Hopefully that makes sense, but that's a big deal in my world. I think that's a very, very plausible thing to want to consider, if that makes sense. Ultrasound, we just said, is a little bit better for more dense tissue. Mammograms are great for regular tissue all the way up to looser tissue. One of the questions you guys have, which is a really good question, is when should I stop doing mammograms? They actually say that 75 to 80 is a good time to just stop mammograms. And I think the idea there was that you would likely pass away from something else before a breast cancer would actually grow and become, to the point where that would be what actually becomes your demise. I personally disagree with that. I think a couple of things in medicine just don't keep up with that. Those are old statistics. People, and not just people, women especially, are living longer, staying healthier. You can stop doing mammograms when you decide that your quality of life isn't what it used to be and you are 99. I think that that's probably a good time to stop. Otherwise, breast cancer can be detected all the way out. Most procedures are very, very simple. They are not these huge cardiothoracic procedures or anything of that nature. There's something you can do at 102, survive it well, and do well post-operatively. So I just don't think I would stop. Okay, moving on. Predisposition. I want to talk about predisposition because it's important. We have done, we've just come to such an advancement with respect to, am I genetically more prone to get a breast cancer? Like, how would I know this? All right, first of all, there is something we've used for years. It's called the Gale model, G-A-I-L. You can actually look this up on google.com. Go to Gale model, answer those 5 to 10 questions depending on which model you're using, and it will give you your risk factor. There are things that decrease your risk for breast cancer. Things like, did you have children earlier in your life or later in your life? There are things like, when did you start your period? Younger or older? There are things like, do you have any first degree or second degree relatives that had breast cancer? Nonetheless, it takes all these questions and averages your risk. And then you can see if you're at the average, if you're lower than average or higher than average. And it's good information to have. The concept is that the more information you have, the better decisions you can make. It's called an educated decision. It's as simple as typing it into Google. So please do that. Everybody should do that right after this talk. All right. Furthermore, if you are concerned that you might have a genetic predisposition, what does that mean? Well, my mom and my aunt and my grandma all had breast cancer. I would tell you that if they had breast cancer earlier in their life, maybe before 60, I would say that there might be some mild concern there, and you should consider a testing. Now, I'm not plugging anybody, but I think it's important because people say, well, where do I go get tested? 2 places. One, believe it or not, 23andMe has some good medical genetic testing associated with it. That's not a bad place to start. So if you're going to do a genetic testing, trying to find out your ancestry, it gives you some information. It's not great information by any stretch of the imagination, but it beats nothing, right? Secondly, there's some groups out there. One of them, for instance, is Myriad. These are companies who you actually call. You answer a very brief, short questionnaire. If you get, let's say, 4 out of the 6 or 7 questions are on the positive side, they will actually work with your insurance company, send you a kit, you spit into the kit, you send it back, and you're good to go. They'll do your testing. They will work with your insurance company to get it paid for, and then their genetic counselor will call you and discuss your results. And it's all relatively free, except for the insurance company charge. I think that these are great options for people. This is something that women have fought for for years and it's all come to fruition. I just don't think I would waste it. I wouldn't waste that opportunity. So that's my talk on predisposition. Exam. All right. Not going to do my own exam, but I'm going to show you a couple of things. All right. One, lymph nodes. Lymph nodes really change the game from stage 2 to stage 3. It makes a big difference, right? So we're talking about tumor size is one thing, right? It's under 2 centimeters, 2 to 5 centimeters in size. I mean, 5 centimeters is that. And 5 centimeters or greater. But if you think 5 centimeters, how can that go undetected? Easily. If you're a very large-breasted woman, that is something that can be well hidden in there. You don't even have to be a large-breasted woman. What if you've always had dense breast tissue and I've always been lumpy and bumpy? Well, that is something you hear all the time from women. And it's interesting because they go, oh, I've just always been that way. So you just dismiss lumps and bumps because, well, I've just always been that way. Not a good idea. Don't dismiss lumps and bumps. Get your mammogram, get your ultrasound, because at that point you have a background. So what you can do is eliminate the background noise, right? Oh, I can compare last year's mammogram to this year's mammogram. These lumps and bumps have always been there. That thing is new, or that bump has changed. That bothers me. That is an indication to go get a biopsy. All right, on your exam, when you want to feel for lymph nodes, there's 3 places to do it. Find your collarbone, which is your clavicle, just here, or right by my tattoo, over here. You go just over top of the clavicle, and you want to kind of feel down into that divot. What you're feeling for is something that feels like a coffee bean, literally. If you feel one of those, I'm not saying you should be concerned, but it's something to look into. It can be from a sinus infection. These things come down our digastrics and our sternocleidomastoids, and kind of all these nodes can get big too. But this is somewhere you could get lymph nodes. Number 2, if you take the middle of your chest, go just off to the right or the left. Now, you're not going to feel your ribs, but I want you to feel for, again, coffee beans, little beans or marbles that kind of move around. And lastly, at the armpit. Believe it or not, and I always found this kind of interesting and funny at the same time, the breast has a tail, and we call that the tail of Spitz because some Dr. Spitz decided to name it. The breast ends right where the hairline would be or is. So right as you see that hairline, that's where the breast ends. You need to push this tissue against the chest wall. You absolutely need to push it hard. I tell all my patients in my office, and for those of you who are old enough, the Princess and the Pea. If you've ever heard this story, it's basically about a princess who sleeps on a mattress, and if she can feel the pea that they laid at the bottom of like 22 mattresses, then she's the right one for the prince, right? The concept is, if the breast is a mattress, it's 95% fatty tissue. So you have to push hard against it, against your chest wall, and move the tissue to see if you can roll a little ball, a marble, or a coffee bean underneath it. Then you can actually start to understand your own breast. I am a huge advocate. I actually wrote a paper and presented at the American College of Surgeons years ago, which I probably looked like a doofus. Thank you, Vinay Gupta, for making me do it. But it was about how we shouldn't change breast exams. They were recommending at that time to stop doing breast exams. My point is, how often do you get a breast exam every year? I mean, if you go to a primary care and they do it, maybe once a year. Maybe you have a GYN who does it once a year. Maybe twice a year if they're good. Who's going to know your breasts better than you? I mean, let's say they do your breast exam as well as everyone else's that walks into that office every year. Are they going to remember your breasts? Absolutely not. So the concept being, if you did a breast exam every week, once a week, on yourself, you're going to have your breasts memorized. It's basically mapped out, and you'll be the first one to know if something changes, if something's bigger, something's smaller, something's hurting, something's not hurting. You'll know. That is the first line of defense against a breast cancer, and I cannot say that more emphatically. So do your breast exams. Last part is cover the landscape. I don't care if you're mowing the lawn or going in circles, it doesn't matter. Just cover the landscape. The breast is from the clavicle all the way down to your six-pack, and I know we all have a six-pack, or at least I used to. So you're going to start, and you're going to push down, again, the Princess and the Pea. You got to move the tissue. Move the tissue. It is not just the breast. You've got to start up by the clavicle. If we take the breast and you cut it into 4 quadrants, so cut it just like a cross, 80% of breast cancers are in that upper outer quadrant. I don't think you should neglect the other 3, but the other 3 account for 20%. Evidently, obviously, do all 3 others, but spend more time in that upper outer quadrant. That's important, okay? So that's a game winner right there if you want to look. Furthermore, the last thing you do is squeeze, not the nipple, the areola. The nipple is the part that sticks up. The color difference on the outside, that's the areola. You want to start wide and kind of push down and squeeze. Don't pinch, squeeze, and push down, because you might see some discharge. It could be clear, it could be green, it could be bloody nipple discharge. These are things to just bring up to your doctor. It doesn't necessarily mean you have a cancer. It could just be a cyst. It could be a little papilloma. But the point is, it's a change. If it wasn't there last week and it is here this week, it's a change and you should address it. So I think that's important. All right, now to the surgeon's part of this talk. Hopefully I haven't taken up too much time or bored you. Let's talk about surgical options. All right, let's talk about 2 scenarios. A woman walks in, or a man walks in, not ignoring my men, but a person walks in to my office. They have either had a mammogram or ultrasound, an MRI or something, and there's some concern, or they had already had that and somebody, primary care, gynecologist, somebody sent them for a core needle biopsy, which we can talk about for just a second, and they already have a pathology result. All right. If you come to my office, scenario 1, you come to my office and you went in for a mammogram, they called you back, they wanted to do another shot or an ultrasound. Okay, we have an area that's concerned. We call this BI-RADS scoring. There is a BI-RADS, 0, 1, 2, 3, 4, 5, 6. Basically, if you start at 0, we need more pictures. A 1 is nothing. A 2 is there's some stuff here, but we're really not concerned about it. It looks benign. 3 is there's some stuff here. I'm not going to say it's completely benign, but it doesn't look bad. Maybe we should get some more pictures, but let's not wait a whole year. Let's just do it in like 6 months. 4 is there's some stuff here. I'm concerned. Maybe we should consider a biopsy. A 5 is there's some stuff here. I'm very concerned. We need a biopsy. And a 6 is basically we already know this is cancer. Okay? That's the scoring system that the radiologists use. Now, you come to my office. If the radiologist has recommended a biopsy, guess what you're getting? You're getting a biopsy. Here's why. Let's go back to the old surgical adage. Do not let skin stand between you and a diagnosis. I was told that by a very wise surgeon, and it is one of the most important things I've ever learned. It is a diagnosis. A diagnosis is based on pathology, tissue in your hands. It used to be, just 15, 20 years ago, that if you had that, you were coming to me and we're going to do an incisional biopsy. You were going to go get anesthesia. You were going to get an incision, and you're going to get cut, and there's going to be a hole, right? And I'm going to deliver tissue that way. We don't have to do that anymore. Like, radiologists have gotten amazing at this. They numb you up with a little tiny insulin needle. They go through that numbed area with a bigger needle, and they have a machine that has a little vacuum on it. It sucks tissue into it, and they take multiple biopsies of the concerning area. That goes to the pathologist. It's usually not a horrible experience. Some people say it was miserable, but it's rare that it is. Some people are just hard to numb. But furthermore, now you have tissue, and all you had was a teeny little incision. I mean, a teeny tiny incision where the needle went in. Get that done. Get it done. All right, now you will have tissue in hand. So that if you came to my office with just a mammogram and ultrasound, then that's what we're going to do. So that we have tissue and we actually have something to talk about. Now, I will tell you, 70, 80% of the time, that biopsy comes back negative. It comes back benign, and we're good to go. And that's wonderful news. But of course, it's going to be anxiety provoking, right? There's going to be about a week's time. You leave my office, we schedule this biopsy, a couple days later you get the biopsy, and it takes 5 to 7 days for that specimen to come back from the pathologist, and the whole time you're biting your nails and wondering why Dr. Rad didn't call me yet. But it's worth it, because at the end of the day, we're going to have a diagnosis and then we have something to talk about. Okay, one of the things they do with that biopsy is leave a little, it's usually a stainless steel or titanium clip. And they leave that clip where they took the bites, so that if that does come back benign, they can look at that in your future mammograms or ultrasounds and go, oh, we took a bite of that, we know that's benign, don't worry about that. And if it ends up coming back as something we need to cut out, like a cancer, then I don't have to guess where it's at. I know exactly where it is, the marker's there, we're good to go. So that's very, very important. All right, now both scenarios are the same, right? So now you're a person coming back to my office or coming to my office for the first time with the diagnosis. The benign stuff we can talk about, but mostly we're going to follow you very carefully. We're going to get further mammograms in 6 months, make sure nothing's changed, and then bounce you back out to a year. All right, if it comes back and it's the nightmare. The nightmares come true, right? This came back as cancer. All right, the bomb has dropped. A couple of things I want everyone to think about for your friends, your family, and hopefully not yourselves, but maybe yourself. Number one, when you go to the surgeon's office, you bring a friend, a family member, a loved one, a husband, a wife, a somebody. You bring someone with you. That's important. You're only going to hear about 50% of what's being said, and you need to hear the whole thing. That person is your sounding board. That's important. They're going to be there to reassure you. And typically that person is with you through the whole process. So they're your sponsor, they're your backup, and they're going to be there for you. That's rule number one. Bring somebody with you. All right, you need the moral support, period. Okay, number two, you want to leave that office with a plan. A plan of action makes everybody feel better, period. It makes the surgeon feel better. That's important. Okay, so what do I mean a plan of action? Okay, this is what we're going to do. In my office, and you walk out, I'm going to set you up with your team. I want you to have your team set up right off the bat. You're going to have a medical oncologist, maybe the radiation oncologist, your primary care is going to be on board. If you need any clearances, they're going to be on board. Genetic counseling is on board. Everybody's on board. We just get your team put together. That's important. All right, you know everybody, you meet everybody. If there's somebody you don't like, we change it. You need a team. You're the quarterback. You're the quarterback, and we're playing for you, and that's important. Number three, or whatever number one, this is really important too. Who's the boss? You're the boss. I can't tell you that enough. I am sorry to all the surgeons who still feel like they should just tell people what they should do and how they should do it. That is not how I operate, and I don't think that's the way we should do that anymore. People are educated. Dr. Google is not evil. I'm not going to tell you he's always your friend, but he's not evil. If you have a good website, a Hopkins website, a Mayo website, something good, there's good information out there. People aren't coming in blind anymore. People are educated, and I love that. And if you're a physician who's concerned about that, maybe you should just up your snuff, because there's a problem there. You want your patients educated. We love that. So come in, be educated, ask good questions, get a plan. All right, now, what are the options? When I say you're the boss, you're going to pick your surgery. All you need, or all your loved one needs, is education. So this is what I would tell my patients. So this is what you can share with friends, or share this video, or whatever. I think that this is important. You're sitting in front of me. We have a diagnosis of a breast cancer. There are different kinds of breast cancers, but the huge majority are invasive ductal cell cancers, some lobulars, and then there's some, less than 2%. If you have a diagnosis, let's start with the easiest one, DCIS. That's ductal cell carcinoma in situ. In situ means it wants to stay where it's at. Yes, it's a breast cancer, but it does not want to spread. If you're going to get a breast cancer, get this one, because it has a very slow chance of actually metastasizing to your lymph nodes or anywhere else. Now, you say, well, if it never metastasizes, do I really need to cut it out? Yes, you do. it has this 40 to 50% chance over your lifetime of turning into the kind of cancer that does want to spread. So you still need to cut it out. There is a small debate, pretty much jury's out, of whether or not you should have radiation or chemotherapy afterwards. Typically we do radiation. It's just spot radiation at the site where we cut it out. Typically chemotherapies aren't needed. Sometimes we'll do some estrogen blockers or things like that. But I always defer to my medical oncologist and my radiation oncologist because that is their job. It is what they do. I can weigh in, I can educate you, but at the end of the day, that's what they do. And that's part of your team. That's why they're on your team. All right, that's DCIS. You still need to cut out. You don't need to check lymph nodes because it doesn't spread anywhere. And you probably need radiation and maybe an estrogen blocker, but not true chemotherapy. Okay, now let's move on to an actual cancer. All right, if you come into my office and we're talking and you have a cancer and we get through the pathology, reviewed it, is it hormone positive? Is it not hormone positive? Estrogen, progesterone, Herceptin. These are things, what does that mean? Well, that means that it has an estrogen receptor on the cancer. And does it have 10% estrogen receptors, or is the whole thing covered, 100% estrogen sensitive? Same thing with progesterone, same thing with what we call HER2/neu, which is a drug called Herceptin, which works really well against those kind of cancers. We test definitely for these three. Why? Well, because they would guide our treatment afterwards. If it's really positive for estrogen, we can block your estrogen in your body, which comes from either your ovaries, right? Or if you're postmenopausal, the only other place you really get a lot of estrogen is if you're taking it, you're wearing an estrogen patch, or obesity, believe it or not. Obesity actually has a 7-fold increase in breast cancer, and the reason why is fatty tissue, adipose tissue, makes its own supply of estrogen. It's not nearly as much as an ovary makes, but it can make it. So those are things we should consider. Same with progesterone, same thing with Herceptin. That's why we need to know those. Okay, what are the surgical options? There's two big ones. We all know the mastectomy. That is where you remove the entire breast tissue. Typically these days we leave the muscle. That's called a radical mastectomy. We don't do that very often anymore, if at all, unless it's grown into the muscle. The reason why is huge studies have shown there's no difference. There's no change in outcome. We used to do that back in the day. We don't do that anymore. All right? The mastectomy is a wonderful surgery. It removes all the breast tissue. There's no concern really about margins, and we test your lymph nodes at the time, right? Now, the other option, lumpectomy, okay? What is lumpectomy? It used to be called quadrantectomy. It used to be called an extensive lumpectomy, things of that nature. It's all the same. That means we usually go in and we just do, a melon ball scooper around your lesion. Try to get a 1 to 2 centimeter margin on the lesion. So we've got it all. Now, what's the difference? I will tell you right now, this is very, very important. The difference, as long as you add spot radiation to your lumpectomy, the difference between a lumpectomy and a mastectomy is the same. Their prognosis is identical most of the time. There's some caveats. Triple negative cancers, which means all those hormones are all three negative, estrogen, progesterone, and Herceptin. Your negative receptors for all of those. Those are a bit more aggressive tumors. But the data is changing all the time on these. And again, that's why we have a team. Your oncology folks, your radiation oncology folks are in the game with us. Now, I will tell you a lesson I've learned, and it's a very powerful lesson. So men, listen up. When a woman walks into your office, every one of them is different. Treat them as an individual. I have had 92-year-old women walk into my office with a very large breast cancer, and they tell me right off the bat, you are not removing my breast. Okay? I've had 28-year-olds walk into my office with a very, very, very small breast cancer, easily removed with a lumpectomy. And they say, I want bilateral mastectomies. Oh, I got some questions. Great, I'll come in on those. Bilateral mastectomies and immediate reconstruction with implants. Okay, You cannot assume what the patient wants. I don't try to. Again, it's education. You help me make this decision. That's important. Okay, so sentinel lymph nodes. Let's talk about that before we move on to the big decisions. Sentinel lymph nodes are, right before your surgery, you'll get an injection in the skin around your breast. That injection goes through the lymphatics to the lymph nodes. We call them sentinel because they're just like sentinel guards, right? If you go to the parliament, the guys who are marching around with the top hats and the stiff jackets, those are called sentinel guards. If you tried to storm the palace, they're the first guard you're going to run into when you get there. Okay, so what does that mean? Well, it means that if we inject you with that stuff, it goes down, I can use a little Geiger counter and find those lymph nodes. I only have to take 2 or 3 instead of all of your lymph nodes. And if those are negative, we're anywhere from 92 to 98% certain that your cancer did not spread to those lymph nodes. So we don't need to take the rest of your lymph nodes, which is wonderful, right? We are saving people from having lymphedema and other issues like that. That's a big, big deal. You would do that with any breast cancer. It doesn't matter with a lumpectomy or mastectomy, because that's going to decide whether or not you continue dissecting out the rest of their lymph nodes or not. So everybody will get that. That's important. You should find out the day of surgery when you wake up if your lymph nodes are positive or not, because those are the first things you send to the pathologist while the patient is asleep and you're finishing the surgery. The pathologist does what's called a frozen section, which is anywhere from 86 to 96, 97% effective, and they can tell you, no, there does not look like there's cancer here. The only time, and I've told you, it's happened probably 3 or 4 times in my 17 years of career, that I've actually had to go back and tell the patient, you know I told you they were negative on frozen section, but on permanent, where they actually put it in formaldehyde for days, it came back with a little tiny focus of cancer. And that's okay. We would rather know that than just to go ahead and assume they were negative. But that happens so rarely. But that's important. You'll know that when you wake up that day. All right, mastectomy. It's important that you know that a mastectomy is where you remove the breast tissue and then you usually end up with a scar straight across. There's a couple options. We can do nipple sparing, where you literally leave the nipple on and then you just take all the breast tissue. When I say all the breast tissue, if you're a good breast surgeon, you should get somewhere around 95 to 98% of the breast tissue. So you're leaving 2 to 5% behind. That's because nobody's perfect. All right, that's just how that works. But that significantly decreases your risk. Why would somebody pick a mastectomy? You would pick a mastectomy because I'm young. This is a breast cancer I got at 41. And oh my God, and for the rest of my life, if I just did a lumpectomy, for the rest of my life, every time I go in for a mammogram, every single year, I'm going to have an anxiety attack, I'm going to be upset, I have 3 children, this is really anxiety provoking for me. Okay, a mastectomy may be a really good option for you. You're removing 98% of the breast tissue. You were very young when you got that cancer. You may have a genetic predisposition. It is a good idea, maybe, personal opinion, to get a mastectomy. And if you're young or old, it doesn't matter. You can get immediate reconstruction. By the way, Congress decree, they have to pay for your reconstruction. So if you choose to have implants done, fantastic. They will be paid for by your insurance company. You should know that. That's important. Nonetheless, it is another surgery on top of it, but you can do immediate reconstruction at the same time you do the mastectomy, or it's down the road. That's another personal choice. But nonetheless, that is a viable option. What are the other reasons to have a mastectomy? It's a huge tumor. It takes up the majority of your breast. By the time you do a lumpectomy, you've basically removed the whole breast anyway. Okay? What about that genetic testing? It came back and showed that you do have a genetic precursor towards breast cancer. That is a really good reason to have a mastectomy. And then we can talk about it another time, or maybe later if I have a second, that there are some genetic disorders that cause breast cancer, ovarian cancer, and maybe pancreatic cancer. So maybe you need to have your ovaries looked at too. These are very important things. The only other real good reason, in my opinion, and I'm sure there's others I'm not thinking of right now, but we have another one called multicentric disease. I had a patient last week with this. They have one nodule here and another one here and a couple little guys over here that they couldn't biopsy, but they're concerning. Well, you can't do lump, 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 lump. That would look very, very cosmetically unpleasing. So that patient would probably best be served with a mastectomy. All right. Now, Oh, thank you. Oh, I'm looking at some of these things. These are great. Let's shift gears to the lumpectomy, okay? Why would I want a lumpectomy? Well, you don't have a genetic predisposition. That is not what's going on in your family. Maybe you're just part of that 10% of women who unfortunately got a breast cancer in their lifetime. It's only one spot. It's small. It looks like it's stage 1 disease. You are fond of your breasts. They're your breasts. It feels invasive to do more than you have to. Radiation therapy, I'm going to tell you right now, is tolerated very, very well. A quick dunk on radiation oncologists. This is wonderful. We used to, your grandmother or your grandmother's mother used to stand in front of a cannon and just get blasted with radiation. That is not what happens anymore. These guys use a spot cannon right at the area. It is typically a 5 to 10 minute thing. You walk in, you're walking out in 10 to 15 minutes. They did a spot thing. Maybe some people say they get a little tired, but typically it's not a big deal. A little sunburn to the area of the skin, it is not a big deal. There's somewhere between 15 and 35 treatments typically. It just depends on how old you are, or the aggression of your cancer, how the margins were. But this is something that's very, very well tolerated. So I do not shy away from this for women. But a lumpectomy, again, requires radiation to make it the same outcome, the same prognosis as a mastectomy. So, it's early disease. You can get a good cosmetic result with a small incision. We make another small incision in your armpit to look at the lymph nodes, and you're good to go. 2 small incisions, you heal really well. Cosmetically, we don't, at least we shouldn't as surgeons, cause big divots in your breast anymore. That's not the case. All right, so a lumpectomy is a great option. Now, I got to consider, okay, maybe you're 58 and it's your second breast cancer. Then you got to ask yourself, maybe they can't pick up this genetic abnormality, but why did I get a second one 15 years later? Another reason to maybe consider mastectomy over a lumpectomy, or not. I mean, again, these are things you need to think of. I will tell you the lumpectomy is a little bit easier to recover from typically, but I will tell you neither one of these surgeries are horribly painful. They typically aren't. Now, I'm not going to say they're not ever. That's not true. But typically they're very, very well tolerated. So again, it's something to consider. All right, that's enough for the surgical options right now. There's certainly more, but I just wanted to say that. All right, on top of this, I will say that I want to put a plug in for plastic surgery.